Hello everyone, my name is Yuzo. This is my topic for this week is Crohn's disease. Let's first take a look at a case study. Z is a 35 years old Jewish descent male. He works as a taxi driver in the city. Recently, he experienced frequent diarrhea, which prevented him from working. Today, he came into the clinic and we had a physical examination on him. The HNP reveals that he has lower right abdomen tenderness. So this preliminary diagnosis will be Crohn's disease. So what is Crohn's disease? Crohn's disease is also called ileocolitis. It's an idiopathic inflammatory disorder. It affects any part of the GI tract from the mouth to the anus. Most commonly, it affects distal small intestine and the proximal large intestine. It's kind of around the ileocecal valve. Sometimes, I put the picture here because sometimes it's kind of hard to distinguish Crohn's disease from ulcerative colitis because they both can happen in the large intestine, which may most likely have abdominal pain, and they both have diarrhea, and their symptoms generally were similar. So what are the risk factors? Here's a few. The first one is family history. So let's say if Z has Crohn's disease, if Z's parents have Crohn's disease, most likely Z would have Crohn's disease. Smoking can relate to any disease. It's harmful to our body anyway. Jewish descent. Earlier we mentioned Z is a Jewish male, so he definitely had this risk factor. Z is our urban taxi driver, so he may have the urban residency risk factor. Z is 35 years old male, so he definitely less than 40, so he carried this risk factor as well. The last one may not related to Z's background, but it is a standing risk factor. It says slightly more prominent in women. So what causes Crohn's disease? Why people do have Crohn's disease? Well, first, let's take a look at the genetic aspect. See, the CART15 and NOT2 gene mutation is associated with 35 to 45% of the cases. So this gene normally resides in our genetic pool, but if there's any mutation to these two genes, you can possibly have Crohn's disease. So on top of these two genes, but there's many other genes that identified, but these two are more prominent. They cause 35 to 45% of the cases. That is huge. These two genes, they mainly code for a protein which involves recognition of gram-positive or gram-negative bacteria. They progressively respond towards normal flora. So think about our GI tract is lining with in our gut with full of E. coli, which function as nutrient observer, nutrient converter, and they also help digest molecules, then break down the molecule into micronutrients for our body to digest, to take in. So the normal flora, E. coli is gram-negative. So if you have this gene, which typically recognize gram-negative, and your body, your immune system won't kill normal flora E. coli, then you will not have a problem. But in case there's a mutation, your body, your immune system doesn't recognize and gram-negative E. coli, so it will fight regardless. So it will cause the inflammation going on in your body. So which the inflammatory process, which Th1 mediated inflammation with activation of leukocytes and cytokine, which causes these injuries to the GI tract of any segments. The leukocytes releases inflammatory substance like prostaglandins, leukotrienes, protease, reactive oxygen species such as hydrogen peroxide and nitric oxide. They can further cause inflammation and injuries. So this is kind of like worse on top of bad. The elevated IgG immunoglobulin can also associate with the severity of the disease. So if you have higher immunoglobulin, which can cause more inflammatory process, so it will cause a more severe grade of the disease. Let's take a look at pathophysiology of Crohn's disease. So the inflammation and the injury that we just talked about, it will start in the intestinal submucosa, which is a lining of the gut, and the most inner lining, or you can say the outer lining of the gut. The inflammation will then spread across the intestinal wall to mucosa and the serosa layers. This progression will involve the neutrophils, infiltration of the crypts, and it eventually can cause a lot of abscess to form and the crypts to destruct. So both in the large and the small intestine can be involved, like I said. But the ileal column is the most common segment. The ileal column, it's like we said, is close to the ileocecal wall. Those are the area that are most affected. It does have the skip lesion pattern, like I said at the beginning of the picture. Here, you can see the skip segment. It's not consistent. It's like you got some here, and then you got some down here, and then you got some on the left, you got some on the right. So it's not consistent. It's not like continuous. It's just, it's segmented. It eventually, the inflammation and the injury can cause the cobblestone projections, kind of like this in the picture. It looks like cobblestones, as you can see. The inflammation of the edema, the fibrous stricture, can narrow this lumen of the intestines. Clinical presentations. Let's pay attention to this, then we can identify what Z present to our clinics with today. So generally, some people just doesn't have much of symptoms, no specific symptom. They just complain of irritable bowel. Others can depend on the inflammation, the injury, location of the GI tract, and the severity of the disease. They will have different signs and symptoms. But the typical ones will be abdominal pain, diarrhea, passage of the passage of the blood and mucus, water nutrient malabsorption, ileum tenderness. What I'm saying is, if it affects in the ileum, it will cause a tenderness in the lower right abdomen. So think about if affect your small intestine, it will affect the nutrient absorptions, including B12. So deficiency in B12 will results in pernicious anemia. A patient can complain of being tired. It can also cause folate deficiency anemia because folic acid cannot be absorbed. So these two anemia can cause a lot of fatigue and weakness in patients. It can also cause vitamin D and calcium malabsorption, which then lead to poor bone health. Protein malabsorption, which can lead to hypoalbuminemia, and then there also can be water malabsorption, which can causes a lot of dehydration. If the disease happens in the anal area, it can cause anal fissure and fistula. When you have inflammatory disease going on and on and on in the intestine, it eventually can result in intestinal cancer. So among all these clinical presentations, Z may have irritable bowel. He may complain of abdominal pain at times. He definitely complain of diarrhea. He may or may not have passed blood and mucus in his stool. He may not have noticed, but he probably had before. We haven't done the labs on him, but he may have some B12, folic acid, and vitamin D, calcium, protein deficiency. So let's take a look at how we do treatments. Earlier we did mention it's disease is an idiopathic disease that related to gene mutation. So to treat gene mutation, we can use some immunomodulants such as TNF alpha blocking agents. This can be used to treat the fistulae, abscess, perforation, and relief of the obstructions. The more invasive method to treat this will be surgical removal of the segments of intestine or the whole intestine if it's more segments are involved. Removal of the small intestine can result in small bowel syndrome, which we already kind of talked about. It can lead to B12, vitamin D, protein, and folic acid malabsorptions. I forgot to mention, but in the treatment here, we can also throw in some laboratory test labs can test what the patient's deficiency in so we can supply